I reported on the EORTC 18071 randomized phase 3 trial that compares adjuvant therapy in stage 3 melanoma. These are lymph node positive melanoma patients after having undergone a lymph node dissection, to compare ipilimumab in the adjuvant setting to placebo. So it's a double-blind randomized phase 3 trial. And what I reported on was that now we have, at a median follow-up of 5.3 years, mature results, so we can report on the impact on overall survival. And it leads to prolonged overall survival. Last year, in the Lancet of Oncology, we already published on the primary endpoint, the impact of ipilimumab on relapse-free survival, RFS. And it was significant, but of course, these are the events that come in early, and we could report on the primary endpoint already last year at a median follow-up time of 2.7 years. Now, we have 5.3 years and a minimum of 4.5 years of follow-up. And so now the impact on overall survival is reported and has been published online this morning in the New England Journal of Medicine. The risk reduction for death is 28%. That means, in terms of hazard ratio, the hazard ratio for overall survival is 0.72. I can add to that all the survival endpoints are perfectly in line. So the impact on overall survival has a hazard ratio of 0.72. The impact on distant metastasis-free survival, hazard ratio 0.76. Hazard ratio on relapse-free survival is 0.76. That translates into an absolute difference at 5 years of 11%. So overall survival with ipilimumab in this trial is 65% at 5 years, compared to 54% for the placebo arm. Also for the other endpoints, the absolute difference in rate is 11% between the two curves. So it's very, very consistent results. So ipilimumab is not an easy drug to handle because it induces immune-related adverse events. So immune-related adverse events are a form of autoimmune disease that is unleashed by ipilimumab. The most important one is gastrointestinal, so it gives diarrhea and it can give full-blown colitis. And this happens in terms of grade 3-4 events in 15 to 16% of patients. Now, this can be handled by, you must immediately stop ipilimumab and you must give high-dose corticosteroids to calm down the phenomenon. And so the ipilimumab prescribing physician is the one who will be most reactive. So the patients must be instructed to contact only their ipilimumab prescribing physician to avoid that somebody else would say, well, this is just diarrhea, let's wait for another 4 days and see what happens. That you cannot have. So the other important immune-related adverse events are endocrine, especially if it concerns a hypophysitis. Hypophysitis means that it knocks out the pituitary gland. This happens in 4.5% of patients in the adjuvant setting for a grade 3-4 event. It's nasty because the likelihood that you will need lifelong hormone replacement agents is there. Rare are neurologic immune-related adverse events, but they can sometimes happen. And we've had 2 cases of Guillain-Barré syndrome, where you lose muscle function temporarily. It's like a viral syndrome. And so overall, we had 5 cases of patients who died to drug-related adverse events. That's 1.1% in the trial. 3 of them had colitis, 2 of them with a perforation. And the 2 other patients, one had a myocarditis, autoimmune, and one had a Guillain-Barré syndrome, who eventually died of multi-organ failure. So it needs to be monitored very closely, and in my opinion, it should be run by centers who have ample experience in how to deal with ipilimumab and how to early recognize these kind of immune-related adverse events.